Hi, I'm Erika Todd with the Housing Finance Agency, and I just wanted to mention several things. And I know enough to be dangerous about the rehab issues, but the Housing Finance Agency has for many, many years funded single-family rehab, and in the substantial does require that the rehabilitation and the housing meet energy standards, air quality standards, and that sort of thing, because we know how important that is in terms of long-term cost savings to the homeowner, but also around health issues. So that's something that we've been doing for many years, and Josh Burton was here, or Mike Hanley at the agency could certainly tell you more about that. In our supportive housing design standards, we have required those kinds of elements to be part of the design, and the plans are evaluated by Advanced Energy or other energy partners. So we consider that important and allow for that in development costs. The other thing I wanted to mention in supportive housing and the linkage between the healthcare sector and how the healthcare sector is pretty smart. And a number of our supportive housing projects, local hospitals have paid to have a nurse as part of the staff in supportive housing development. And it's not just because they're being nice, it's because it's a lot cheaper to pay for a nurse to provide a lot of wellness kinds of activities as well as intervention than it is to have 5 people go to the emergency room. And so I think those kinds of things are helpful. The other thing is that we have a number of projects that started longitudinal studies from day one when residents moved in. And so now we're getting a lot of good data on how much supportive housing really is saving the community. And I hope that will turn into a way to recycle those dollars back into affordable housing. But I think it's important to have that data from the beginning, because otherwise it seems to be sort of anecdotal. Well, we think it saves money. But when you can really demonstrate it with real data, I think we'll have a better case in the future.
Thanks, Mary. Why don't you pass the microphone down that way? We have another question down at the end of your row.
Hi, I'm Linda Shaw with the North Carolina PACE Association.
Oh my God, I didn't even see you.
PACE is Programs of All-Inclusive Care for the Elderly. And I would just like to echo what Mary Rika just said about savings to the hospitals. I think that there is a lot of opportunity in North Carolina now, as North Carolina is still trying to figure out what we're going to do with our Medicaid program, whether it's going to go managed care, whether it's going to be something else. And I think that as we're looking at models like the patient-centered medical homes, that folks are becoming more and more aware of how housing and housing cost, let me rephrase that, how health costs are related sometimes to housing issues. PACE, for those of you who have not heard of PACE, PACE is actually a capitated model. And that means that we get the money to take care of folks from the minute they step in the door usually until they die. And if they eventually need to go into a nursing home, PACE pays for that. The whole purpose of PACE is to keep people out of nursing homes and in the community. So therefore, I walked in as you were talking about the air conditioning situation. PACE could have paid for that air conditioner. And that's exactly what the program does. It looks very comprehensively at what is the need of these elderly folks, 96% of whom are Medicaid eligible. So we're talking about very poor, very frail elderly who consume the far highest percentage of our Medicaid cost. So lots of times we think about health issues in housing, we're thinking about lead paint and children and all of that, all of which is very important, and we need to capture it early. But in terms of the cost savings to Medicaid tend to be at the higher end, the older end of folks toward the end of their life. So there is a model out there that allows for that fully comprehensive look at everything that the individual needs. And again, I think we have opportunities in North Carolina to further these conversations between the housing community and the health community. And the hospitals will definitely be a huge part of that because they're getting deemed right now for emergency home visits. So emergency room visits.
Medicare.
If you really, really want to get them real interested, send all your people to the emergency room and you'll get that.
That's right. There you go. That's the solution, is to send everybody to the emergency. By the way, the 80% of the Medicaid, and there's a group called duals, I won't go into that, is consumed by 20% of the population, seniors and people with disabilities. And people with disabilities under the age of 62 are the fastest rising group. There are also folks who need these supports. So there are ways, actually, interestingly enough, to generate those savings and then be able to redistribute that, though, across all age groups of people with disabilities, so that and or other, disenfranchised groups. So there's some very interesting ways that this redistribution can happen. And PACE, when it's working well, as Linda just said, is a dynamite approach, underutilized in this country.
Yeah, maybe another program to highlight is the Capable approach. This is a program in Baltimore that we're hoping to expand to a number of other jurisdictions, but it's basically involves home visits by occupational therapists, RNs, and a licensed handyman. I didn't know handyman could be licensed, actually, but the point is they do minor home improvements, right, that are dictated by the elderly resident. So an example of the intersectoral approach that we were talking about. But certainly you're right, the focus on...
Time for one more question, and Mr. Rowe, you may have the floor.
Rowe gets it.
Well, I'm Bill Rowe with the North Carolina Justice Center, and I don't have a question. It's actually a comment, and this is wonderful and great information. And when we talk about scale, the needs are at such a scale that it's phenomenal in this state and throughout the country, and these are wonderful ways of trying to figure out how to get at it. But I just want to point out to everyone that we're having these fundamental debates in our state legislature, and you will also have them in Congress, about who we tax and how much revenue. And I know it's a dirty word to say the tax word, but the way we're shrinking government at this point and many of the investments in these programs, it's difficult to get there. And just to say that we all need to think about how we can talk about this to shift that, because the needs we're seeing in housing are also in healthcare, are also in our schools, are also in our communities. It's access to higher ed, it's the infrastructure, and at this point we're going, in our view, from the Justice Center, we're heading towards a place where it's really difficult to meet these needs.
Yes.
I've asked Bill Rowe to maybe offer some closing observations, and Bill Rowe, excuse me. Rowe, they're all the same.
With H or W here.
Yeah, but before you do that, I just want to thank everybody who's attended this. I think that this is a rich discussion that we've had. A lot more work needs to be done on this, and thank you for your interest and participation today. Bill?
Well, I would second what Greg just said. I think we've talked about a number of the obstacles this morning. We've also talked about a number of innovative solutions. And of course, the big question is how to bring many of those innovative solutions to scale. And my almost namesake over here makes a very important point about not going to do it without some extra funding. One strategy, and it was talked about in several instances, is the idea of trying to build the business case for these programs. So you do get the participation of the firms and the healthcare providers and so on. I mean, short the federal government and state government turning around and providing more resources, I think we do have to put more emphasis on developing that business case. And there is obviously a business case to be made here for many of these, if not all of these initiatives. So we need to continue to document, to come up with broad-scale data, not just data on 3 people, and to continue to bring that information to everybody. So, and it has to happen at the federal level, at the state level, and at the local level. People need to continue talking about this. To some extent, I suspect we're all preaching to the choir here. The challenge is to go back to your communities and your organizations and to talk to other people about this and to see how you and your organizations can get on board and really help further this very, very important initiative. So with that, again, thanks to David for a great opening presentation, other panelists for great comments, and to the audience for bringing up many important points and programs. I certainly have learned a tremendous amount here this morning, and I hope you have as well. And again, congratulations to DHIC for 40 years of doing healthy housing.
Thank you very much. Kelly tells me that there is a Building Healthy Housing Network that's just gotten kicked off. Did I get that right?
Build Healthy Places Network.
Build Healthy Places Network. You can Google that, and that's just getting kicked off.
Yeah, it's been started by the Doug Judy out of UC Berkeley in California and a number of folks. It's going to be a national clearinghouse for case studies and information on that intersection of health and housing. They've been doing kickoff events all over the country.
Great. Well, thank you again for attending. We videotaped this. I think we'll probably do some editing, probably put it on YouTube and the like. We'll certainly put the presentation on our website as well. And again, thank you very much. And for those of you attending the luncheon, that kicks off at 11:30. I think the door is open. Thank you very much.